Hello.
Yes, ma'am.
Hello.
Hello. Yes, ma'am, you are audible. Aarti is here from technical team.
Hello.
Yes, ma'am, you are audible.
Yeah. Actually, I will present, but I don't know how to share and all. Please
Okay,
tell.
okay. Can I guide, ma'am?
Yeah.
Okay, ma'am. So you have to open your PowerPoint in backend.
1 minute. 1 minute. Be slow. I'm
Okay,
not.
okay.
What should I do?
Ma'am, you have to open your PowerPoint, your presentation in backend.
Just 1 minute.
Okay.
Uh, 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 mm, just 1 minute. Yes, I have opened it. Madam,
Yes, ma'am. Now come on Zoom
there
screen.
is 1 minute. One is PowerPoint,
Okay.
another is one video also. So
Okay. So you have both.
video will be in the last. Video will be in the last, madam.
Hello.
Video will be in the last.
Okay. No issue. So, ma'am, come on the Zoom screen.
Come on the Zoom screen.
Zoom, yes, open the Zoom screen tab.
Yeah,
Now,
yeah,
in the bottom side, you will see one button, green button, share screen button.
yeah. Share screen is there. Yeah,
Okay,
share
so
screen.
click on that, ma'am. Yes.
Okay, fine.
Okay, now you can see the tab. So you have to select the screen, first
Yeah.
screen.
Yeah.
Okay, then blue button will be highlighted. Click on that.
Uh,
Yes. Yes, ma'am. Now your screen is coming. Now open your PowerPoint. I can see
you
your
can
whole
see
screen.
right.
Yes. Now open your PowerPoint.
Yeah. What should I do?
Now you have to open your
Can see now.
PowerPoint, ma'am. Your presentation. Your presentation you have to open, ma'am.
I have opened. Can you see?
No, ma'am. I can't see. I will just see your folder and file.
Here you are screen sharing.
Okay.
Showing. Can you see?
No, ma'am. Not yet. I think you have shared one particular tab. You have to share your whole screen.
Share my whole screen. How to go?
Just click on stop share button, ma'am.
From where? Stop share.
Yes,
Zoom.
stop share.
Zoom.
Yes. On the Zoom, you will be you can see all red button. Stop
Stop
share.
share.
Click on that.
Okay. Stop
Yes.
share. Okay. Stop
Okay.
share. Then
Yes. And now come on. Now click on green button, ma'am. Share button.
share screen. Right. Then
Yes. Now click on first screen. First
first.
screen. Screen.
First.
Yes.
Well, case presentation which I want to
Screen.
present. Right.
Yes. No. You can see one first option three. Yes. Now it is visible, ma'am. So now can you make it full screen mode, slideshow mode?
Okay. It is visible now.
Just a minute. Yes, ma'am. Perfect. Now can you go for the next slide, ma'am? Okay. Perfect. It's visible.
Okay.
Yes. Perfect.
Acha, 1 minute. When? How will
Okay.
I go to the video in the last?
Okay. So where you have save your video, ma'am?
It is. I'll
It is
show
on
you.
PowerPoint or it is on
No,
PowerPoint or any other folder you have saved, ma'am?
that cannot be in PowerPoint. Na video cannot come in PowerPoint.
Yes.
Na?
A video can become, but if it's larger, then we can share. It
Okay, I
how much
ask you
for
at
time?
that time. Huh?
The video is for how much time? Means
1
20
minute
minutes
only.
or
1 minute only.
1 minute. And is there any sound in your video, ma'am?
Not important. Sound is not important.
Okay, okay. So, ma'am, you can share your whole screen when you are clicking on share button. No? So there will be option for just share three button. Just a minute, I'm showing.
That is in the last. You can help me na, at that time.
Yes, just click on share button. Na? Then you can see option screen, whiteboard, iPhone, iPad. That first option screen, you have to click on that, ma'am.
Which one? Which screen?
Screen. When you will click on the screen button, na?
Share screen, right? Yeah.
Yes, click on screen button, blue button.
Okay. It is in this folder, new folder.
No, you have to share your whole screen, ma'am, not any particular tab. You have to share your whole screen, your whole laptop.
Whole laptop. How to go? Share.
Yes,
Share this blue. Blue.
yes, yes. Click on that share.
Share. Then
That's right. You have shared any particular tab, ma'am.
hmm,
Have you opened your video in backend, ma'am?
I should open the video. Yeah, these two are the videos.
These two are the videos, no? Okay, now you okay.
Can
Okay,
you
ma'am,
see?
perfect. Yes,
Can
ma'am,
you
your
see?
video is also visible. Okay, now you can go to the you can close this video.
How to close? I will go to escape.
No. After completing the video, you will be minimized, right? This video.
Okay.
Yes, video is running perfect.
I minimize it.
Yes, ma'am. After completion of your video, you can minimize it, ma'am.
That has come. That has come. Madam,
Yes,
that has
second
joined.
video is also coming. Yes, I can see your video, ma'am.
Okay. No, I am asking whether sir has joined.
No, sir has not joined yet, sir. Just
Okay.
let me check. Yes, doctor has not joined yet.
So I minimize.
Now open your PowerPoint, ma'am. Yes, you can minimize and now you can open your PowerPoint, ma'am.
PowerPoint from here. From here only.
Click on that.
You will be able to see me.
Yes, ma'am. I can see your that cursor. Yes, right.
Oh.
Perfect.
Okay.
Now do full screen. Okay, go to the first slide, ma'am. Yes, perfect. So just let it be, ma'am. Just let it be.
Right, madam. Right.
Okay. Yeah. Thank you.
Okay, am I audible to you?
Yes, sir. You are audible.
Okay. Okay. I think 7 o'clock now. I think we should start.
Sir, just 1 minute. I am going to record this session. Just 1 minute.
Okay.
Sir, good evening.
Okay. Right. Fine. Okay. I think we will start the program now. Saroj will present the case, and I would like somebody to discuss the case, the history part, because without knowing the diagnosis, I think we should be able to discuss the story and whether we can actually come to a reasonable, very close diagnosis, whether it is possible from the story itself, or we can come to a differential diagnosis so that when we do a clinical examination, we can look specifically for the findings which will ultimately help us to come to a proper diagnosis.
Recording in progress.
So that's very important. So we would like to have somebody, any volunteers? Aditya, would you like to discuss the case?
Hello.
Hello, Manjunath, would you like to, Aditya, would you like to discuss? Yeah. Okay.
Yes, sir. I would like to, sir, but I am on call, sir. So any call come from emergency, I have to go.
Oh,
Yes,
okay. That will be a problem. Oh,
yes,
okay.
sir.
Is Karun, would you like to discuss? Or Lakshmanan? Hafiz, would you like to discuss? Manjunath?
Sir, even I am on call, sir. So I am difficult, me, sir. I am also on call, sir, today.
Okay. I think most of you will be on call. Let us hope that there will not be any call coming for Aditya. Let Aditya start. And if he is called, then Manjunath can continue. All right. Let us have a, or both Aditya and Manjunath both can get involved. And ultimately, whoever is available can continue to discuss. And of course,
Yes,
once it comes to the case discussion, Saroj will do it. Okay. Right.
Yes,
Okay.
sir, sure.
So we'll do that way.
Yes, sir.
Okay, Saroj, can you start your presentation?
Yes, sir. Yes, sir. So, 62-year-old female resident of Palakkad admitted to CTVS unit. So, she was admitted to our surgical unit, sir. Okay, sir. Sir, with complaint of easy fatigability for last 4 years. Shortness of breath on exertion for last 3 years. Palpitation on exertion 2 years. Sir, one more complaint, syncope for last 6 months for 2 occasions.
Okay. Right. Aditya, would you like to look at this part with easy fatigability last 4 years, shortness of breath on exertion 3 years, palpitation on exertion 2 years, and also 2 episodes of syncope within a span of 6 months?
Yes, sir. Giddiness? Yes, sir.
No syncope, but
No syncope, sir. No, sir. No, sir.
giddy feeling. Okay. She had something like a gray out, actually a prodromal syncope. Okay, right.
Yes. Syncope for 2 occasions during last 6 months.
Okay, Aditya, would you like to look at from this part?
Sir.
It's a female, so
Yes, sir.
the patient is admitted to CVTS. So
Sir,
obviously the patient is having a surgically correctable.
Sir, any LVOT obstruction,
Yeah,
sir, leading to.
Yeah, why did you think of LVOT obstruction?
Sir, because she fits into all the complaints which are suggestive of LVOT obstruction.
Okay. So LVOT obstruction is a possibility.
With that,
what type of an LVOT obstruction are you thinking?
It can be dynamic or fixed, sir.
Oh.
But more in flavor of dynamic because of long course of action, sir. Long duration of history of easy fatigability and breathlessness.
But is the dynamic obstruction common to present at the age of 62 years? What is the usual age group in which patients with the hypertrophic cardiomyopathy dynamic obstruction present?
Sir, 3rd to 4th decade, sir.
Usually 20 to 40 years. That is the usual age in which they usually become significantly symptomatic. And after 60 years, usually they become less symptomatic.
Yes, sir.
That's an odd point. Okay. Do you think that it's a fixed obstruction of the LV outflow?
Sir, sorry, sir.
Is it a fixed obstruction LV outflow?
Sir, it can be a fixed obstruction, but sir, if it would be because of the old age and everything, sir, we can it can be aortic stenosis as well, looking at the age of the patient, sir.
Okay, she's 62 years old.
So degenerative calcific aortic wall can also lead to this type of presentation, sir.
Okay, what is the odd point against it?
The easy fatigability, sir.
Affects what? Male sex or female?
Some male, sir.
Male. It's a female patient, so we
Is
cannot
there
keep.
no chest pain, sir?
We cannot
No
keep
chest
it,
pain.
we cannot keep it
Angina,
high
no
in the
issue of
list.
angina is there.
No, she had some. But
Good evening.
all. Good evening, Gaurav. All symptoms need not be there. See, the patient had an episode of two episodes of rather gray out. So that will be a point for us to start thinking that whether there could be an LV outflow obstruction. Okay. And anything else? Can it be mitral prolapse with progressive symptoms?
Sir, but the age of presentation will be like somewhat earlier, sir.
No. Mitral prolapse is different types. Patients can present at a later age also. Patients with mitral prolapse with progressive increase in or maybe a caudal rupture, one of the chordae can rupture. They have got a myxomatous degeneration. It's more common in females.
Yes,
They
sir.
can rupture a chordae. They become more symptomatic, and they can have sometimes arrhythmias, which can be which can explain the syncope. So, do you think
Palpitation.
the palpitation
Yes,
is there? So, do you think that
Fatigability also, sir. Fatigability is a very chronic MR can cause fatigability also.
yes, palpitation is there? There is some degree of shortness of breath. So, and also long history, see shortness of breath for 3 years. So it is very
Yes.
slowly progress. It is the volume overload condition, which can sometimes progress very slowly. So do you think that a possibility of mitral prolapse with mitral regurgitation is to be discussed?
Yes, sir. Sure, sir.
Yeah, I think that point I think we have to discuss. Do you think that this can be a dilated cardiomyopathy?
Dilated cardiomyopathy. Yes,
The
sir.
most important point against the diagnosis of dilated cardiomyopathy is that this patient is admitted to
Sir, CTVS side.
CVTS unit unless they are thinking of cardiac transplantation. The patient with dilated cardiomyopathy, you may not get admitted to CVTS. But still, we should discuss that point. Do you think that this could be dilated cardiomyopathy?
Yes, sir. Can be, sir.
Can be.
Yeah, I think the
Sir.
EC fatigability, because EC fatigability is a symptom of what?
Low cardiac output, sir. Low
Cardiac
cardiac
output. Very good. It is a symptom of low cardiac output,
Low cardiac.
and the exercising muscles are underperfused. So EC fatigability is a symptom of low cardiac output that goes consistent with dilated
DCM.
cardiomyopathy. Shortness of breath.
Yes, sir.
Shortness of breath can occur on exertion due to what?
So because of increased PA pressures.
Yeah, increase in the with exertion. If there is an increase in the left ventricular and diastolic pressure, elevation of the left atrial pressure, pulmonary congestion, patients can have shortness of breath. So that also is possible.
Shortness of breath.
3 years. And palpitation, not common, but they can have arrhythmias, and that can also explain about
Because of dilated LA can, yes, sir.
So from the whatever is the initial part of the symptoms, the conditions that we will suspect are
LVOT obstruction, mitral prolapse, and
obstruction. I will
cardiomyopathy.
still keep low in the list because I feel that I would like to think of mitral regurgitation in a patient with mitral prolapse slightly on the higher list. Then I will keep the LVOT obstruction. Usually, I would go for more of fixed obstruction than dynamic obstruction, and LV cardiomyopathy also will consider as a possibility.
Okay.
Can it be rheumatic heart disease? So a female patient, rheumatic heart disease.
So, but if it would be rheumatic heart disease, sir, like if it would be mitral inflow obstruction, the complaint would be of longer duration, sir. And if
No,
it would
that
be
depends upon the severity of the lesion. If the patient had only mild mitral stenosis, mild mitral regurgitation, over a period of time, the patient might have become symptomatic, or maybe the patient may be having. Do you think that it could be rheumatic heart disease?
sir, if it would be severe rheumatic heart disease, he uh, he will be in failure and not admitted to CTUS side for the failure management with all the complaints.
No. She has not developed severe heart failure. That is obvious. But patients with mild to moderate mitral stenosis, mitral regurgitation can get medical treatment as an outpatient and might have been admitted for a surgical treatment to CVTs. That also is still possible. Do you think that this can be, because after all, 62-year-old female, do you think that this is coronary disease?
Yes, sir.
Yes, sir. Can be. Yes, sir. Yes, sir.
No, I think coronary disease always should be discussed in a patient, 62-year-old male or female, presenting with progressive symptoms. I think you should think of the possibility.
Excuse me, sir. Sir, can we discuss HFpEF also, sir? HFpEF, heart failure with preserved ejection fraction diastolic failure.
Yes. Say common. What are the common causes of heart failure with preserved ejection fraction?
Hypertension,
Obesity,
coronary disease,
OSA, obstructive sleep apnea, sir.
OSA, they can also develop. They develop more pulmonary artery hypertension, atrial fibrillation, all those things. Okay, so do you think that a possibility of coronary artery disease also should be considered?
Yes, sir.
So, any other point? AC fatigability. Patient is complaining of AC fatigability.
Anemia.
Yes, I think patient who is having a heart disease and the patient has developed associated complications like anemia, and that can also be a presentation. Can it be thyrotoxicosis?
Yes, sir, but rare. CTVS unit is the
So I think unlikely. When the thyrotoxicosis, which side fails first? Right side or left side?
Sir, right side due to increased.
Yes, it is usually present with right heart failure. Patients with thyrotoxicosis usually present with right heart failure rather than with left heart failure. Okay, so from the initial part, we think that possibilities to be included are we would like to think of mitral prolapse with mitral regurgitation, coronary disease, fixed obstruction, dilated cardiomyopathy. All those things we will consider as possibilities, and we will further discuss after hearing the story part. Okay. Saroj, shall we hear some more part of the story, or anybody else would like to point out any other point?
Sir, aged with pulmonary hypertension, sir.
Yeah, I think that also can be considered. AST with the AC with shortness of breath, palpitation. I think AST can be considered, but usually AST is slightly older because usually AST develops symptoms around the age of fourth or fifth decade,
yes,
late 30s or early 40s. So she's 62, and that's a bit odd, but the female patient is a point in favor of atrial septal defect. Okay, we'll consider that also because atrial septal defect, palpitation, and developing an arrhythmia and developing symptoms is quite possible. And so that also is a possibility. So we'll consider AST also. Very good. Yes. Any other point?
Late onset PH. Late onset PH. PH only PH can we or not possible?
Due to what? Due to what? Due to what?
Due to left heart failure.
Oh, that we have considered few conditions which can affect from the symptoms, which are the possibilities we have already discussed. So now let's hear the story part, then we'll go further. Okay, right. Yes. Saroj.
Yes, sir. The patient was relatively asymptomatic 4 years back when she felt excessive tiredness and fatigue, mainly on exertion. In the beginning, it was while going to the 2 stairs, and later on, it increased day-to-day activity. So she restricted her activity, and according to her, after this, she put on some weight of 2 to 3 kg during this last 4 years. And this fatigue and the tiredness was not associated with any drug intake, but the fatigue was even with the minimal exertion. So it has within a 4 years time, it deteriorated from NIHA class 2 to NIHA class 3, sir.
Class 2 to class 3. Oh.
Yes, sir. During 4 year time, sir.
Oh, class 3 means she's comfortable at rest, but even less than ordinary activity precipitate symptoms. Okay, right.
Yes,
Yes.
sir. So she restricted her activities, sir.
So she's quite disabled. Okay, right. Yes.
With fatigue, she also had a shortness of breath. Sir, 1 minute, sir. With fatigue, she also had shortness of breath, gradually increasing over the past 3 years from NIHA 2 to 3, when she had to consult physician. Gradually progressing, at first climbing to 2 stairs and playing with her grandchildren, and now so much so that she feels breathless even on day-to-day activities like dressing, undressing, taking baths, climbing one stair. Shortness of breath relieved with rest and was not associated with fever, cough, seasonal variation, or expectoration. Her shortness of breath also relieved after taking some medicines which increase her urine output. For last few months, she feels better when she puts two pillow at night. On 2 occasions, she had episode of severe breathlessness 2 to 3 hours after going to sleep, and relieved after assuming sitting posture, suggestive of PND, as it was associated with pink for the sputum as well.
Okay. So from this story, up to this level, our initial differential diagnosis, which is excluded? Aditya?
Sir, we can exclude
The ASD excluded,
Yeah, ASD can be excluded because she
and
has
sir,
got
obstructive lesion also, like sir,
CM and all.
we cannot
we
rule
can't
it out, but ASD is ruled out because she is giving a history suggestive of paroxysmal nocturnal dyspnea, including frothy sputum. So ASD is out. So only remaining conditions are there. Okay, yes,
yes,
go ahead. Okay.
with shortness of breath, patient feels palpitation for last 3 years. At first, she felt increased precordial activities. In the beginning, she used to feel throbbing sensation in the chest with exercise, but it was persistent in nature, which now she feels irregular in nature, going 2 stairs in the beginning and now on the day-to-day activities. Her palpitation now is irregular in nature and relief after taking rest.
Oh, so that means she has developed a what? Aditya?
atrial fibrillation.
Atrial
Atrial fibrillation.
Okay. Now the conditions that we have discussed, which will be the most likely?
Sir, one MVP MR, sir.
Yeah, I think mitral regurgitation should be considered higher in the list because mitral regurgitation is the one which can cause atrial fibrillation compared to aortic valve disease. Aortic valve disease
Yes, sir.
usually because atrial fibrillation can happen, but it's quite late. So of the two or three conditions that we have discussed, atrial fibrillation goes more in favor of a mitral valve disease. And cardiomyopathy also can be considered, but the point against cardiomyopathy is that this patient is admitted to CVTS. So cardiomyopathy cannot be a strong possibility, but we'll consider that also because the atrial fibrillation can be explained by dilated cardiomyopathy also. Okay, right. Yes, go ahead.
Rheumatic MS leading on to a rheumatic heart disease.
Yes, rheumatic heart disease. We have discussed that. That also is possible because I forgot to mention.
MS leading on
yes. Mild mitral stenosis with mitral regurgitation or mitral stenosis, because whenever there is a history of PND, I think as always you should think of a possibility of mitral stenosis.
Yes, sir. So MS goes up in the order.
Yeah, I think mitral stenosis with mitral regurgitation also will be one of the points that we will carefully look for when we are examining the patient. Okay, right? Yes.
The next, associated with fatigue and shortness of breath, she gives history of episodic recurrent giddiness on exertion, followed by feeling of dizziness and near blackout, with one episode of transient loss of consciousness for a few minutes, with rapid recovery to the normal consciousness without any neurodeficit. There was no history of involuntary movement or tongue bite or incontinence during this episode.
No, so discuss. This is suggestive of.
So this is suggestive of TIA, sir.
Yeah, TI. Why do you say TI?
Decrease.
AF with embolic. I am suspecting AF with embolic.
Why can't you think of the possibility that this could be because of two things? One, it can be because of an obstructive lesion, or second, it could be an arrhythmia.
VT, sir.
A transient arrhythmia. Transient arrhythmia, short spell of non-sustained VT, something. Or whether this could be a pulmonary arterial hypertension.
Yes,
Patient
sir.
with mitral disease can develop pulmonary arterial hypertension, and if the patient is having significant pulmonary arterial hypertension, that can result in a blackout.
Yes, sir. Yes.
So we have to think of those possibilities, whether the patient has developed some degree of pulmonary arterial hypertension, and that has very rapidly progressive pulmonary arterial hypertension, and that has resulted in significant symptoms, and the patient has developed a blackout also. So
very rapid AF also can sometimes lead to hypotension.
Yes, AF can, but I would say if the patient is having a blackout, I would think more in favor of a ventricular arrhythmia rather than atrial fibrillation. A blackout is unlikely. The patient sometimes can feel breathless, but okay, there can sometimes, especially if the atrium is contributing for ventricular filling, as can occur in aortic stenosis or hypertrophic cardiomyopathy, atrial fibrillation can suddenly make the patient symptomatic. So atrial fibrillation, but I think we'll keep our mind open. Let us hear more. Okay, right? Yes, Saroj.
Yes, sir. So now some negative is there is no history of chest pain, no history of cough, expectoration, hemoptysis with seasonal variation, no history of hoarseness of voice or dysphagia, no history of fleeting joint pain with fever suggestive of rheumatic fever in childhood, no history of slurring of speech, hemiplegia or weakness or altered sensorium or blood vision or blackening of extremities, and no history of intermittent claudication, edema, abdominal distension, nausea, vomiting, anorexia, oliguria, or nocturia or hematuria. All these absence and no history of cyanotic spell in childhood. She is a known case of hypothyroidism for last 5 to 6 years.
Hypothyroidism.
So one important past history is there. The past history, she had 2 deliveries. The first, the twin pregnancy, she had unexpected swelling of both the lower limbs with shortness of breath. The first twin pregnancy.
Unexpected swelling of both lower limbs.
Both lower limbs with shortness of breath. And second pregnancy also she had a swelling of feet and shortness of breath and palpitation, and she underwent LUCS for the indication was for the mother.
What is LUCS?
That cesarean section.
Okay. Okay. She is because the indication is for the mother.
Mother, yes, sir. Because the first pregnancy was
What did the doctor tell her? Why she should undergo?
The doctor told that her condition of the heart has some problem. That's why, sir, she could not tell full, but sir, she told that she has some problem in the heart, so she needs
Rheumatic MS, can it be rheumatic MS complicating?
But sir, she doesn't know. But sir, she does not know the full details.
See, only thing that we can draw is that probably this patient developed maybe with the volume overload developed mild heart failure, and also because see, mitral stenosis will give rise to severe paroxysmal nocturnal dyspnea and all those things, which is not there. So
PND history is there, sir. PND history is there, sir.
No, that is recently, not during the time of pregnancy.
Yes, sir. Yes, sir. During pregnancy, it was not there.
What is the age of this second child?
So second child, it was 26, around 26 year of age, sir.
She was 26 years of age. That
Yeah,
means
yeah, yeah.
so that is quite some time ago, almost 30, 36 years ago.
Yes, sir. So she had hysterectomy done at 36 year of age.
Oh, what the reason?
Reason, sir, that I did not.
Okay. And at the
Sir,
time
she
of
had palpitation also that time, sir. So second pregnancy, she had palpitation also. So I
Yes,
am still rheumatic heart disease, MS and AF only, sir. I am most probably thinking of that only.
No, that's right. I agree with you that rheumatic heart disease, because she had this heart disease when she was around 20, 25. So rheumatic heart disease comes top in the list. I agree with you there. But I'm not certain whether there is any significant mitral stenosis, because during pregnancy, she did not become grossly symptomatic. Mitral stenosis patients become significantly symptomatic. So
No,
mitral stenosis may be there, but may not be very severe. Mitral regurgitation also may be there. So
sir, she was done urgent LSCS, so she was very symptomatic. That
no, it is
can
not
be the
urgent. I think the doctor
no,
told
no,
her
sir, it is not urgent. It was not urgent, sir.
urgent. Doctor told her that it is better to undergo lower segment cesarean.
Lower uterine cesarean section.
So I think that.
ma'am, what was the anesthesia given?
That I don't know.
Can you
30
tell
years
that?
back.
No, I think
Okay.
I fully agree with you that rheumatic heart disease should be considered, because anybody who is around the age of 20 years having a pregnancy and the lesion was detected and had to undergo some form of an intervention, I fully agree with you that rheumatic valvular heart disease is a possibility. And it is the mitral stenosis which gives rise to problems and not mitral regurgitation.
Yes, sir. Yes.
Maybe because, see, gynecologists are really worried. See, obstetrician is really worried when they think that the patient is having some heart lesion. They immediately becomes very apprehensive, and they try to cut short the pregnancy. But that should not be the way in which we think. I think we should think that well, this patient had some degree of heart failure because the patient developed edema, and well, I agree with you that mitral stenosis should be there in the differential diagnosis, but whether it was a severe mitral stenosis at that time is from the clinical story, I can't be certain. But it can be a progressive symptoms, and the patient might have developed more and more symptoms recently, and that may be the thing that is happening now. So rheumatic heart disease actually becomes the first possibility.
So can it be like cardiomyopathy leading to the dilated cardiomyopathy or restrictive ones?
Bit unlikely.
36 years.
36 years,
36
she has
years.
problem. I think a bit unlikely. I think cardiomyopathy also is very unlikely. I would definitely go for rheumatic heart disease. Whether it is a mitral stenosis dominant mitral regurgitation, I think that's a different question. But I would now consider rheumatic heart disease as the first possibility, because during the pregnancy.
CAD is also a chest pain, no history of chest pain, so ischemic heart disease also somewhat.
No, see, during second pregnancy, she had a problem, even first pregnancy. So she was only 26 years of age at that time. So everything else becomes secondary. I would definitely go for rheumatic heart disease, because she is symptomatic at the age of 26, or rather at that time when she had her pregnancy at the age of 26, the doctor detected a heart lesion, and somebody recommended that she had to cut short her pregnancy by a lower segment cesarean section. So all put together, I would definitely go for rheumatic heart disease as the first possibility. Mitral prolapse could be a possibility, but the 26-year-old person detection of heart lesion and requiring a lower segment cesarean section because the obstetrician thought that she may go in for complications, I would definitely think rheumatic heart disease as the first possibility. And also admitted in the CVTS, so they are planning some surgical procedure.
Yes.
Yes, most of the
Second is
mitral
prolapse also we will consider, we will not exclude that, but our focus will be on rheumatic heart disease. Okay, right? Yes.
The next, the personal history, she takes non-veg mixed diet. Family history, no history of diabetes, hypertension or similar illness in the family member.
Okay.
So, yes, sir.
No, don't reframe now. Okay, Aditya, we have to make a differential diagnosis. So, what first possibility is?
Sir, first we'll put a rheumatic heart disease as
Rheumatic
the
heart disease.
top one, sir, seeing the all history.
Yeah, rheumatic heart disease,
Second,
mitral disease, maybe combination,
yes,
both MS and MR. Okay, right. Yes.
SMR.
Second
Yes,
possibility?
Then we can put MVP MR.
Yeah, I think MVP MR also can be taken as a possibility. Many patients with MVP can present quite young in age, and sometimes
Yes,
so that possibility we can consider. Yes. Do you think that is an LV outflow obstruction?
Yes, sir. Last possibility, but we can, sir.
I think very unlikely. 26-year-old female, unless it is a congenital aortic valve disease.
Maybe, sir, that time they won't.
Very bit low in the list, but because it's a female patient, then you have to think of the possibility of bicuspid aortic valve. All put together, I would consider that bit low in the list, because only point that makes me think that we have to conclude, we have to include that as a part of the differential diagnosis. History of something like a syncope, maybe an early blackout. So that makes us think that whether there is an LV outflow obstruction. So then we have to think whether the patient has got rheumatic heart disease, mitral valve, as well as aortic valve disease.
Yes, sir.
So that because the LV outflow obstruction symptom of blackout makes us think that whether the patient has got some degree of LV outflow obstruction. Okay, other things are out. I think hypertrophic cardiomyopathy, all those possibilities are with low in the list, unlikely.
Yeah.
Okay, right. Okay, any other point anybody would like to discuss? And also patient had a paroxysmal nocturnal dyspnea. That is one point we have to consider, that mitral stenosis is may be there, because whenever there is paroxysmal nocturnal dyspnea, never forget to think mitral stenosis as a possibility. So always you should carefully, when you auscultate, you should carefully look for a metastolic rumble by turning the patient onto the left, and carefully look for a metastolic rumble, because PND means always think of mitral stenosis, especially in a female.
Yes.
Okay, right. Saroj, we will go for the physical findings.
The physical patient conscious, cooperative, oriented to place, person, and time. Their height 152 centimeter, weight is 58 kg, BMI 23. Their upper segment, lower segment ratio is normal. Pallor, cyanosis, jaundice, edema, clubbing, koilonychia, and so thyroids are not visible. Now, sir, neck vein, sir. Neck vein visible 4 centimeter above the sternal angle in 45 degree. A wave is absent, V wave prominent, normal respiratory variation. The pulse.
You have not mentioned the height of the V wave.
Sir, this 4 centimeter is the height of the V wave only. Sir, A wave is not visible.
Oh, only. So what is the main jugular vein pressure? See,
8 plus 4, 12, 12 into 0.7.
Jugular vein pressure, you have to describe two things. One, what is the mean height of the jugular vein pressure? Which wave is prominent? And what is the height of that wave? So here, the mean jugular vein pressure elevation is 4 centimeters above the sternal angle at 45 degrees. All right. A wave is absent and B wave is prominent. And what is the height of the B wave?
So B wave was a little 6 centimeters, a little more than this.
It is usually when a wave is prominent, and when you are seeing about the mean jugular vein pressure, the wave is usually higher than the main jugular vein pressure by about 3 to 4 centimeters. So if I am to take this as the main jugular vein pressure, I would consider that V waves are about 8 centimeters above the sternal angle. Okay. What about the X descent, Y descent?
Sir, X and Y descent, sir. Sir, if A wave is absent, sir, what should I say about the
X descent will be absent, ma'am. A is absent and X will be absent.
No, no, why
Not necessary.
A is absent, then X. How you can make
what are the when we look at actually the X descent, there is it has got X and then X dash. What are these two components?
Sir, X component will be immediately after the A wave, while X descent will be after the carotid obstruct.
And what is the mechanism? What is the reason for X descent? Initial one.
X descent.
First is due to atrial relaxation. Second is to ventricular contraction.
So in a patient with absent A wave, and the patient is in atrial fibrillation, initial X will not be there.
Yes, sir.
So what about the next one?
So that will be there, sir. X
That will be
descent.
there. That will be there. X dash will be there. You will be able to appreciate the following C wave. You should be able to appreciate the X dash. X dash is due to what?
Sir, due to the contraction of the
Carotid obstruct, sir.
Eh? It is due to
No.
so ventricular contraction.
ventricular contraction. And what happens there? It is not enough to say ventricular contraction.
Sir, at that time, sir, the floor of the right atrium is pulled.
Now the tricuspid valve is pulled down, resulting in X dash wave. So in a patient with atrial fibrillation, you can still see a part of the X descent. Then when a V wave is prominent, can it be absent?
Sir, what question?
If the V wave is prominent, can the X dash be absent?
No, sir.
Yes, it can be absent. If there is a significant tricuspid regurgitation, the V wave becomes actually CV wave. Okay. And then you will not be able to get the X dash. You have to make a comment about the Y descent also. Why are you not making a comment about the Y descent?
Yes, sir.
Why it is important?
Y will be prominent, sir. If V is prominent, then Y will be prominent. If V is prominent, then it should be prominent.
No, yes, V wave is prominent. I am asking Saroj.
Yes, sir.
She did not make a comment about the Y descent.
No, sir. There was some type mistake, sir. Yeah, I should have written, sir. I just forgot.
Oh,
yes,
so
sir.
why
is very important because here, sir, we have to the tricuspid valve. We will be looking with the Y wave.
Yeah, because we
don't have anything else here to see the.
It's important to mention about the Y descent because you have described a prominent V wave. So the patient may be having associated tricuspid regurgitation, and you should get an idea whether the patient is having associated tricuspid stenosis also.
Yes, sir. Yes, sir. Yes, sir.
So you should have made a comment whether V wave is associated with a good Y descent.
Sir, Y descent normal, sir. Not blurred.
Okay, right. Okay. So from the JVP, it's mildly elevated. A wave is not there. Then V prominent. So we are thinking of tricuspid regurgitation, and the Y descent is normal. So unlikely to have any significant tricuspid stenosis. Okay, very good. Yes. Go ahead.
So now, sir, pulse. Sir, 90 per minute. Normal volume. Irregularly irregular. Sir, apex pulse deficit is 8. No radial or radiofemoral delay. Condition of the arterial wall is normal.
Okay. Conclusion. Patient most likely is having.
Sir, having atrial fibrillation, sir.
Atrial fibrillation. Very good.
Yes. With controlled ventricular rate.
Okay. Very good. Yes.
Yes. So the blood pressure is 100 by 60 mmHg in all 4 limbs. The respiration 26 per minute.
Okay.
Abdominothoracic.
Okay. All right. Very good. Yes.
Ma'am, SpO2 I am not seeing. Saturation, SpO2, saturation.
I did not take it.
I was searching.
Cyanosis was
saturation.
No. It's
but it's not very important because this patient, all the 4 limbs are actually looking normal. So there's a facility you can have a look at it, but I don't think that is going to affect the diagnosis. Okay. That's not very important. Okay, right. Yes. Next one. No, next one.
The next one. Sir, CVS examination, sir. Inspection. Chest symmetrical, normal in shape. Apical pulsation visible in 6 intercostal space. So 2 centimeters, I should have written 2 centimeter lateral to the mid-clavicular line. So no visible pulsation is seen, no scar mark, no sinus or dilated vein seen, no parasternal, suprasternal or epigastric pulsation seen, and no pulsation in the back. So this inspection, sir.
No,
So here,
okay. No, apical pulsations.
sir,
No parasternal, suprasternal. Okay, right. Okay, right. Yes.
sir, only apical pulsation visible in the 6th intercostal space.
All right, right. But nothing else is visible.
Yeah.
Parasternal is not there because see, you have described a prominent V wave.
Yes, sir. Yes, sir.
So
Yes.
when we are saying that parasternal pulsations are not at all visible, there is slight controversy is there. Why there
Yes.
is a prominent V wave and parasternal pulsations are not visible? Okay, right. Yes. That's not matter. Okay, right. Yes.
Palpation, sir. Sir, inspectory findings are corroborated by the palpation. Sir, apex beat 6 intercostal space. It is localized LV type, forceful, hyperdynamic.
Okay, very good. Very good description. Very good. Okay.
Sir, no thrill is felt. Sorry, sir. P2 is palpable. In the
Did you turn the patient in the left lateral position and try for?
Yes, sir. Yes, sir. Yes, sir. To see the thrill, sir. I turned the patient in the left lateral position, but I did not get the thrill.
What thrill is felt in the apex usually?
Sir, usually it's a diastolic thrill.
Yeah. Usually, if at all you are feeling a thrill, usually it will be a diastolic thrill. Can
Yes,
you feel a systolic thrill at apex?
It can be, sir, if
Yes, sir.
severe.
Sir, that Gallaudet phenomenon.
Oh. Still, thrill is a bit unlikely.
Oh. Otherwise, sir.
Anybody?
Sir, HOS.
Not likely.
Yeah, it's very much.
Can you feel a apical thrill?
Sir, MVP MR?
No.
No.
You can get a thrill in apical muscular VST. If you are feeling a thrill at the apex, I think you should always consider a possibility of apical muscular VST. Mitral regurgitation is very, very unlikely to give rise to thrill because the direction of the jet is posteriorly and hence there cannot be a thrill in the anterior portion.
Yes.
Okay.
So whenever you get a thrill in the apex, always consider whether it could be a muscular VST. Okay, right? Yes?
Yes, sir. Sir, P2 palpable in the left second intercostal space. Grade 2 left parasternal heave is present. That is a late systolic.
Okay. Late systolic. Okay. Yes. Gaurav, why did she describe that as a late systolic grade 2 left parasternal heave?
Due to pH leading on to.
She said late systolic.
Systolic. Sir, can it be LA? Increased LA pulsation?
Yeah, LA pulsation. Transmit LA pulsation is the one which you get late systolic parasternal leak.
Yes, sir.
But then you have to describe it. How will you differentiate it from an Saroj? How will you differentiate LA pulsations from RV pulsation?
Yes, sir. Sir, in case of RV pulsation, sir, we will get it along with the apex.
Okay, timing will be along with the apex. Okay, right. 1, 2.
And sir, second, sir, sir, it will be, sir, I don't know, sir.
Anybody else? If the parasternal pulsations, the transmitter pulsation on the LA felt in which intercostal space?
Yes, sir. Yes, sir. Sir, in case of transmitted pulsation from the LA, it will be, sir, in third intercostal space.
Yes.
Whereas,
sometimes rarely it can be felt in the fourth also. Mostly
but,
it is third intercostal
but RV will be more lower down, sir.
Yeah, fourth and fifth intercostal space. And RV, can the RV pulsation be felt in the third intercostal space?
Yes, sir. It will be of RV outflow.
Outflow conditions.
So, like upstream.
Oh, very good.
And one more is there, sir.
Top also.
No, sir, very prominent. Sir, DOR. I forgot.
What are the conditions in which you can get RV outflow pulsations? And RV outflow pulsation means that RV.
In PA.
No.
No, sir. It is specific, sir. Sir, I think intact.
Otherwise, RV endomyocardial fibrosis.
Yeah, yes, sir. Yes.
RV endomyocardial fibrosis. And also patients with see, one important feature is that in these two conditions, where there's RV outflow pulsations, there will not be any RV body pulsations.
Yes, sir.
Epstein's anomaly as well as in RV endomyocardial fibrosis, you will be able to palpate the RV outflow pulsations, but body pulsations will not be felt. But in a patient with ASD, you can palpate RV body pulsations, and as well as you can also palpate the RV outflow pulsations. So ASD will give rise to RV outflow as well as RV body pulsations. Then another important point to differentiate RV pulsations from the transmitted pulsation of left atrium is that if the pulsations are felt in the epigastrium, it is
Then it will be RV, sir.
Always RV and not transmitted pulsations of the left atrium. Okay, so you must always whenever you are getting a pulsation which you think is transmitted pulsation, you must always palpate the epigastrium for any RV pulsations. Yes, you wanted to ask some question?
This is mostly to LA, sir. This pulsation.
This looks like from our description, it looks like an LA pulsation because she has said that it's a late systolic, or obviously meaning that it is occurring after the apical impulse.
Yes, sir. It's not.
Atrial fibrillation, we can expect this, sir, in this case.
Beg your pardon?
Atrial fibrillation, sir. Can we expect atrial fibrillation this parasternal this because of atria?
Now, what is the mechanism of this late systolic pulsation? What has it to do with atrial fibrillation?
It is just the regurgitant volume is felt.
No, it is actually the regurgitation into the left atrium which makes the left atrium suddenly dilate during systole, and which is transmitted along the RV outflow and a part of the aorta onto the chest wall.
Okay.
So it has nothing to do with atrial fibrillation. It is only associated with the mitral regurgitation and the expansion of the left atrium because of the regurgitant jet.
Thank you.
Okay, right. Yes. Okay, go ahead. No treatment.
Auscultation, sir. Sir, S1 variable intensity, S2 normal split. Sir, P2 is loud. Sir, here little, sir, it is a little wider split, sir. Not very wide, sir. I just, sir, it is a little wide variable split, sir.
Yeah, what do you mean by little wide and not?
I mean, sir, wide, sir, wide variable split with P2 loud, sir.
No,
Yes, wide split.
Yes, sir.
What do you mean by wide split?
Sir, sir, during inspiration, sir, it will be, sir, normally also, sir, wide.
No. Usually when you use the word wide variable split when you can appreciate a split during inspiration as well as during expiration.
During expiration, sir, that's what, sir. Sir, yes.
There's a normal moment. So you are getting a normal moment. That means the S2 is narrow during expiration and wide during inspiration. But in both phases of respiration, the S2 is split. Are you getting?
Sir, in both the phases, I am getting split.
Okay, right. And P2 is loud.
Yes, sir. P2 is loud.
Okay, right. But tell me the condition where this variable split is there in S2 variable split. Conditions.
Yes, sir.
MR, very good. MR.
VSD.
VSD, very good.
Then complete RBBB also we can.
Complete RBB, very good. RBBB, very good. Yes. What else?
The pulmonary stenosis.
Pulmonary stenosis, very good. Yes.
And
What-
sir, if it is a sir PAPVC or TAPVC?
Yeah, not TAPVC, PAPVC.
PAPVC.
With the intact intravenous receptor.
Yeah.
PAPVC with the intact intravenous receptor. Very good. So these are the conditions in which you can get wide splitting of the second heart sound, which is moving. Sometimes in moderate degree of RV dysfunction also you can get, not severe. When it becomes severe, it becomes a fixed splitting.
Yes, sir.
What's a moderate degree of RV dysfunction, you can get a wide splitting of the second heart sound.
Yes.
Okay, right. Paradoxical splitting condition where there can be paradoxical splitting,
Sir, paradoxical sir, severe aortic stenosis,
stenosis.
complete left bundle branch block.
Yes.
Severe PA.
Eh? What did you say?
The severe LV dysfunction.
Okay, severe LV dysfunction. Very good.
Then, sir, RV pacing or V.
Okay, very good. RV pacing. Can it occur in
Type
aortic
B WPW.
eh?
Sir, type B WPW.
Type P WPW, very good. Can it happen in
Sir, PDA also somewhere without Eisenmenger, like PDA with PH,
Yes.
which has
PDA.
not Eisenmengerized.
not PH, large PDA?
Large PDA.
Why? What is the mechanism?
So because the flow on the left side is very high, as a result, sir, A2 will be delayed.
Okay, one reason. More important reason is not that. When a patient with large
Yes,
PDA,
and sir, moreover, sir, pulmonary valve is also closing earlier because sir, the flow is from the sir, directly hitting. Is it that?
no.
No.
When a patient with PDA, what will happen to the systemic vascular resistance?
So
What
decrease.
will happen to systemic vascular resistance in a patient with PDA?
It will decrease, sir.
It will decrease. So when the systemic vascular resistance decreases, what will happen to the hangout interval of the aortic valve?
Increase.
It will increase. So that can also give rise to paradoxical splitting. And similarly, in patients with aortic regurgitation, you can get paradoxical splitting because of the longer hangout interval of the aortic valve. Okay. So these are the conditions that you have to suspect. So, okay, now go ahead.
Sir, opening snap is heard medial to the apex. No S3, no S4, or no click is heard.
Now, when you are hearing opening snap, you should also mention what is the A2.
A2 and open, sir, A2 opening snap gap is high, not so it is 0.08, more than like that, sir. It is, sir, I did not
What is
mention.
the normal? Now, what is the normal A2 interval? Not normal. What can be the range? A2
Sir, range is, sir, it is if it is
0.08 to 0.12.
No.
Sir, 50 to 200 milliseconds.
No, not 200.
120, sir.
Yeah, well, it can go sometimes go up to 140 maximum. So the A2 interval is around 50 milliseconds to about 130 to 140 milliseconds. And which one is moderate? How will you give an idea?
sir, A2OS less means severe MS.
Eh? Oh, yes. What will be the range?
Sir, like 50 to 80 will be, sir, severe.
Yes.
More than 100 will be mild.
Okay. Yes.
110.
Very good. Roughly it is right. About 50 to 80 will be moderate, severe. 80 to 100 or 110 will be moderate, and above 110 to 140 will be mild. Okay. So the longer the A2, what is the timing of the S3?
Sir, S3 is after opening step.
Okay, it's the timing is slightly beyond the opening snap. It will be around 140 after around 140 milliseconds, 140 to 150 milliseconds after A2. Yes. What is this A2 interval indicate?
It indicates that pressure difference between the LA and LV. If
No,
it
no,
is
what is the phase of the cardiac cycle?
sir,
A2 indicates what phase of the cardiac cycle?
Isovolumetric relaxation.
Yes, isovolumetric relaxation phase. And what is the explanation for close A2OS interval and severe mitral stenosis?
Sir, because the pressure difference between the LA and LV is very high, so it will open fast.
It will open earlier because the pressure, when the pressure drops from the LV, for example, let us say the normally when the at what time does the aortic valve close? When the pressure LV pressure is below what level?
Sir, aortic mean pressure.
Yeah, it closes when the LV pressure falls below the aortic mean pressure. And at what pressure does the mitral valve open?
When LV diastolic LA reaches the LV diastolic pressure.
No, LV pressure falls below that of the left atrial pressure.
Left atrial.
So in a patient with mitral stenosis, the left atrial pressure is significantly elevated, and because of that, the time gap between the or the time pressure drop required to open the required will be much less in a patient with aortic with mitral stenosis, because the main aortic pressure remains the same, but the left atrial pressure is elevated, and because of that, the opening snap occurs earlier and resulting in a close A2OS interval. Can you tell me a few conditions where the A2OS interval may not give you any idea about the severity of mitral stenosis, or even patients with severe mitral stenosis can have a long A2OS interval?
Association with MR or Lv dysfunction can also.
More important than that is
Associated aortic stenosis.
aortic stenosis is variable. What happens in aortic stenosis?
So then the pressure, LV pressure will not fall fast. So then, sir, the A2OS gap will be more.
Yeah. So that is that you have to say the aortic stenosis with the LV hypertrophy with
hypertension also, sir.
Hypertension. Hypertension is the first one you should say, because in hypertension the A2 occurs at the mean aortic pressure, which is higher, and it takes time to drop. So even in presence of severe mitral stenosis in a patient with systemic hypertension, the A2OS interval can be away.
Sir, high.
It can be delayed. It can be prolonged. So that's one important point. Second is that in patients with the aortic stenosis, if the LV impaired LV relaxation, that may take longer time for the LV pressure to fall, and these patients can have, even in presence of significant mitral stenosis, can have an A2OS interval longer.
The so, same thing can happen in LVF also?
LVF, no. LVF, as long as the diastolic function is not impaired, then there is no problem.
Okay.
There should be impaired LV relaxation.
Okay.
Okay, right? Yes. Murmurs.
Sir, murmurs. The pansystolic murmur, grade 3/6, high pitch, hollow character with radiation to axilla, heard with the diaphragm of the stethoscope, and it increases on expiration, sir. So radiating to axilla, sir.
Oh.
So at the apex, sir.
You can also describe whether the murmur is better audible in the left lateral position.
Yes, sir. It is better heard in the left lateral position.
And if the murmur is better audible in the left lateral position, then all these characters we know the lesion is mitral.
Mitral regurgitation.
Regurgitation. Yes, very good. Yes.
Sir, a mid-diastolic rumbling grade 2/4 murmur heard at the apex with the bell of the stethoscope in left lateral position, breath held in expiration. MDM murmur also extends occasionally to the late diastole with pre-systolic accentuation heard in the short cycle, followed by the long cycle, sir, because patient has got a AF, sir.
Okay. So how will you assess the severity of mitral stenosis by auscultation in a patient who is having atrial fibrillation?
Sir, this pre-systolic accentuation, if we can hear in a short cycle followed by long cycle, then sir, I think I have written it opposite, no, sir?
No, see, what are in a normal patient, in normal sinus rhythm, what are the two important points by which you assess the severity of mitral stenosis clinically?
One is A2OS gap, short.
Yes, and
sir, pre-systolic accentuation
No, pre-systolic. Length of the murmur. Length of the murmur. Length of the murmur.
Length of the murmur. Yes.
Sometimes in a patient with mild mitral stenosis, you may hear only pre-systolic accentuation murmur. Pre-systolic murmur only. So it is not the pre-systolic accentuation, but the length of the murmur.
Okay.
In a patient with atrial fibrillation, what are the cycles in which you will look for opening snap, the A2I interval, and what is the cycle in which you look for the length of the diastolic murmur?
So length of diastolic murmur will be heard in the long cycle and the pre-systolic accentuation and opening snap in short cycle, sir.
Not short cycle. You have to modify that. First one is correct. The length of the diastolic murmur is assessed in the long cycle, and the A2I interval. Anybody? The cycle
immediately after the long cycle.
Yeah, it is following immediately after the cycle following the long cycle. What is the reason? Explain hemodynamically.
Sir, because because of the long cycle, sir, LA has emptied well.
Yeah, because of the long cycle, because the prolonged diastole, there is a good decompression of the LA. Okay.
LA. As a result, that we will be able to differentiate A2 and opening snap well.
Well, not only that, if in spite of the LA decompression, A2I interval is close, that obviously means the patient is having severe mitral stenosis. Even after the prolonged diastole, the proper decompression of the left atrium has not taken place, and if the A2I interval is short, that obviously means that patient is having severe mitral stenosis.
Yes.
Similarly, if the patient is having a long diastole and the rumbling murmur is heard till the late diastole, obviously means that there is a good gradient across the mitral valve, even when there is a long diastole. So these 2 points will help us to make out whether the patient is having severe or what is the grade of the mitral stenosis. The A2I interval is assessed in the cycle following the long cycle, and mid-diastolic rumble should be assessed in the long cycle.
Yes.
Excuse me, one more point, sir. Excuse me, sir. Sir, here P2 is loud, so that can we say that MS is severe? It is the prominent MS leading on to PAH now.
Yeah. We say when the patient has developed a PAH, there is an additional point also. There complication. Complications also can tell us about the severity of mitral stenosis. So PAH, development of atrial fibrillation.
Yes, sir.
But directly related to the auscultatory finding, it is the A2I interval and the mid-diastolic rumble, which will help us to decide the severity of mitral stenosis.
Yes.
Okay, right. Yes.
So can we say P2 is loud, so that is also leading on to severe MS was there leading on to PH.
Then you have to rule out. Then you have to rule out other causes of P2 loud, because patient can have COPD, other causes of pulmonary arterial hypertension. So you have to exclude that. So it is an indirect point, because patients with complications like pulmonary arterial hypertension or patient with atrial fibrillation most likely will have severe mitral stenosis. So that's an additional point, but directly related to mitral stenosis is opening snap, A2I interval, and the length of the
murmur.
But the presence of complications also additional point to assess the severity of mitral snap. Okay, right.
Sir, can you repeat that S2OS gap? Why after a long cycle?
In a long cycle, what is your name?
Dr. Sriram.
Sriram, in a long cycle, what happens to the left atrial pressure when there is a long diastole?
There will be more LV filling will be there, sir.
More LV filling will be there, prolonged LV filling. So what will happen to the left atrium? Left atrium is better decompressed, and left atrium pressure?
Better decompressed, and so LA pressure will be less, sir.
No, left atrial pressure will be less. So even in spite of a long cycle, somebody is in the car. Yeah? So even in spite of a prolonged diastole, if the left atrial pressure is still elevated, then you can get a close A2I syndrome. So that is why in a when you are looking for A2I interval, you auscultate in a you should assess in a cycle after the long cycle.
Oh, okay, sir. Okay, sir.
Okay, right? Yes. Okay, Saroj.
Sir, yes, sir. The diagnosis, sir. Valvular heart disease of rheumatic etiology in the form of.
No, don't write in the form of a
Yes, sir.
rheumatic heart disease.
Acquired valvular heart disease, ma'am. Acquired valvular heart disease.
Yes, sir. Yes, sir.
No, rheumatic etiology is rheumatic heart disease. That is definitely acquired.
Sir, yes, sir. Rheumatic.
Heart disease. So you when you discuss the diagnosis, there should be 4 points. 1, etiology. That's the first one. 2, morbid anatomy. That's what is the lesion. 3, altered physiology, especially left to right and right to left in a congenital heart disease. 3, severity of the lesion. 4, severity of the lesion. And 5, associated complications. So this is the way you should mention. Etiology, morbid anatomy, severity, complications. Okay, right? Yes.
The valvular heart disease of rheumatic etiology in the form.
Rheumatic etiology you should say first. Rheumatic heart disease.
Rheumatic heart disease. Sir, mild mitral stenosis with severe mitral regurgitation with the moderate. Yes, sir. With moderate tricuspid regurgitation, moderate pH in atrial fibrillation with controlled ventricular rate without evidence embolic episode. Currently in NIHA 2.
Let me go to your physical findings. One, did you describe a murmur increasing on inspiration?
No, sir. Sir, I did not get. I know, sir. Only on the basis of sir prominent V wave, I wrote moderate TR. So that's what I wanted to discuss with sir you. Whether can I write or not?
No. You cannot write the moderate
TR.
So, acha, sir.
Not
Okay. Okay, sir. Okay,
see,
sir.
V wave is very variable because see, what decides the V wave in a patient with a tricuspid regurgitation?
Sir,
and JVP is normal, sir. So we cannot.
Sir, RV function.
JVP
was RA compliance.
No, because it is the degree of tricuspid regurgitation and the RA compliance.
Yes, sir.
So even in patients with mild or moderate tricuspid regurgitation or mild tricuspid regurgitation, if the RV is non-compliant, you can get a wave. And the A wave is not very prominent. See, you described that the JEP is elevated 4 centimeters above the sternal angle. That is not much.
Okay, sir. Okay.
So very severe.
Yes, normal.
So I would put it as a.
I will say severe MS, sir. Sir, severe MS here, sir. We cannot say mild. I will say it is a severe MS because F is there and pH is there. So severe MS only.
Yes,
F and pH have come out.
I think I will not. Mild MS is unlikely. I would definitely go into.
Yes, sir.
Moderate.
And patient symptomatic also. Patient is symptomatic also. So severe MS and moderate MR. I will most probably.
No, you have to describe the A2I interval as well as the length of the murmur before you make a comment about the severity of mitral stenosis clinically.
Sir, A2OS gap was more. That's why, sir.
A2OS gap is more. But A2OS gap is more taking into consideration of the symptoms because see the patient is having associated mitral regurgitation. So during systole, large volume of blood is going to the left atrium. So when large volume of blood is going to the left atrium, what will happen to the left atrial pressure? It will get elevated. So in presence of mitral stenosis, even moderate mitral stenosis in presence of mitral regurgitation will have significant symptoms. So since the patient is having mitral regurgitation, which is definitely there, and also left atrial pulsations are there, I would definitely go for only moderate mitral stenosis because even the significant symptoms, including PND, can be explained by associated significant mitral regurgitation.
Okay.
So A2I interval will definitely give a clue, but in presence of mitral regurgitation, moderate mitral stenosis also can be symptomatic. Okay. Yes.
So moderate pH is also there. So that's why I am telling severe MS. Moderate pH is there, so severe MS leading on to complication of pH and AF. No, I am more in favor of severe MS with moderate MR only. It is the MS predominantly.
I agree with you that MS should be there, but because of the paroxysmal nocturnal dyspnea, that's a very important point. But what I am saying is that your diagnosis should be based on all put together, not only on just PND only. For PND only,
Yes,
there was
sir.
only
Sir,
one
my
episode.
first,
Yes.
sir, 62-year female, sir. Sir, I will start from the 26-year history, sir. History is
At
prolonged,
that
sir.
time, she
Hello?
did not have much problems because after that she led a normal life. She underwent a hysterectomy. So all those things were there. So at that time, she might have had only a mild or at the most low moderate mitral stenosis. It cannot be any significant. Or probably over a period of time, she might have developed more symptoms, or whether she might have more, the lesion might have progressed and might have become definitely moderate. But my assessment whether it is moderate or severe, of course,
Yes.
PND will be an important point. But I will definitely look at whether what is the length of the mid-diastolic rumble after the long cycle. After in the long cycle, and also we look at the A2I interval after the long cycle. So that point should be looked into before we commit whether it is severe mitral stenosis. But I
And sir,
definitely,
moreover, sir, if it is a severe mitral stenosis, so this shortness of breath is just only for 3 years now.
oh, that's
Sir,
it. But she had a paroxysmal nocturnal dyspnea. That obviously means that at that
that
time,
also, sir, now only, not.
yeah. See, now only we are discussing what is the present severe condition. So
Okay.
when there is paroxysmal nocturnal dyspnea, what is the LA pressure?
Sir, PND, sir, 25.
Patients with chronic
No, sir, 18, more than 18, sir.
No. PND means
25.
PND is definitely more than 18 or mostly usually very often 25 or more. And patients with pulmonary edema means obviously in a patient with chronic mitral stenosis, it could be about 30.
Yes, sir.
So I agree with the argument of Gaurav that we have to consider severe mitral stenosis because of the symptom of PND. But I would take both into consideration because I will not take only the just one symptom, or I will not consider just the second heart sound loud, but I will consider everything put together. What is the A2I interval and also what is the length of the murmur all put together. But PND definitely is a point that patient's left atrial pressure has gone up to around 25 millimeters, and usually that indicates moderate to severe mitral stenosis. So I agree with him that definitely a possibility of severe mitral stenosis should be in our mind. Okay, right.
And so moderate pH, that is also a point. Moderate pH is written, so that is also a point for severe MS.
The
Moderate pH.
Moderate pH may not be for severe MS because this patient is having associated mitral regurgitation. So if the patient is having only pure mitral stenosis, yes, because that moderate pH may indicate severe mitral stenosis. But if the patient is having associated mitral regurgitation and there is a combination lesion, you may get a moderate pH even in presence of severe mitral regurgitation with moderate mitral stenosis. So that alone may not be enough. But PNDs, I agree with you that that is something which should caution us that most likely the patient may be having severe mitral stenosis. Okay, right, yes. So let us put it as moderate to severe or even severe mitral stenosis with what about the mitral regurgitation?
Mitral regurgitation, severe mitral regurgitation.
Significant mitral regurgitation because the patient is having
Cardiomegaly is there.
Yeah,
The
Cardiomegaly is there.
cardiac enlargement and a forceful LV apex tells us about the severe mitral regurgitation. And also in a patient with mitral stenosis, very unlikely that the patient can have such significant cardiac enlargement and a forceful LV apex.
Yes.
So all put together, I would go for severe mitral regurgitation with
moderate mitral
stenosis. That will be my diagnosis.
Yes.
And moderate pH.
Actually, sir, in one of the classes they told, sir, one doubt, sir. In one of the classes they told it is better not to give moderate MS, always be mild or severe in exam. So that's what the only question, sir. Can
No,
you
no,
say
no.
moderate MS or
Moderate
it is
can definitely
or
give.
it better to be on the
I would not have said that.
all
Because
to be or mild MS or severe?
no. There is a term known as moderate. I would not have said that. Because whenever you think it is
Okay.
mild, moderate, severe are three terms used, and there is nothing like only mild and severe. There is a moderate, moderate
Yes.
also. There is no question about it. I would not have said that. I never say that. Probably you would have misunderstood.
No, sir, in one of the other classes.
Eh?
Yes. No, not you, sir. In one of the other classes, sir, they told better to commit either as mild or severe.
No.
Because moderate can cause more questions.
No.
No, that is for mitral regurgitation, not for mitral stenosis.
Even mitral stenosis, any lesion, you can use moderate. You should be able to support it. That's all. See, it is your argument that matters. So here the patient is having paroxysmal nocturnal dyspnea, so it is not mild. So second, this patient is having severe mitral regurgitation. So on top of that, the patient is having associated mitral stenosis. So I would like to consider a possibility of moderate mitral stenosis with severe mitral regurgitation.
Yes.
Okay, right? Yes.
Sir, ECG and X-ray, sir.
Okay, ECG. Let us look at the ECG. What do you expect in the electrocardiogram, Gaurav?
Sir, I expect a LA enlargement, sir, because AFA was there. LA enlargement, and that we have second that LA enlargement and
will not get LA, na?
This patient is having atrial fibrillation, so LA enlargement is difficult to assess. But mostly we will be look for the whether it is a LV or
Volume.
dominant or RV dominant. If it is LV dominant, that will tell us that patient is having severe mitral regurgitation, and our impression that it is only moderate mitral stenosis is correct. So okay, Saroj, interpret the electrocardiogram.
12 lead ECG. Sir, the rate is around, sir, 90. Sir, irregularly, sir, patient in atrial fibrillation.
Okay, very good.
And sir, axis is just 90.
No, no, not 90.
Not 90. 2.
AVL is flat, sir. AVL
is very
flat,
small, very small.
Sir,
so
1
92 AVL.
Transition
and AVS is equal, so it will be, sir, around 45.
AVL, the transition is from AVL to lead 3.
Sir, 1 and AVS both are same, sir.
No, AVL is flat.
No, if you look at the transition is from AVL to lead 3. So that will be near about 45. I think
45. Yes, sir. 45.
45.
Yeah. Okay. Yes.
Sir, A waves are P waves not seen,
Okay.
and sir, QRS complexes. Sir, I cannot say ventricular hypertrophy.
No, there is no evidence of any ventricular hypertrophy.
Yes, sir.
But,
Sir, narrow QRS.
Of the if you look at the dominance of the ventricle from the electrocardiogram, then it's more likely which one?
LV.
And what would you like to do? Because the apex beat is in the 6th intercostal space, and it's enlarged. So
more lateral we should go.
Yeah, you should take one space down.
Down and more lateral.
Take up to lateral up to 77, so that sometimes the LV forces can be better picked up.
Yes, sir. Yes, sir. But from this ECG, sir, looks that MS is not that significant, na, sir?
From the electrocardiogram, but then in spite of the cardiomegaly, we cannot pick up LVH by voltage criteria. So I will keep my mind still open, saying that a moderate mitral stenosis is a possibility.
Yes, sir.
Of course, I agree with you that if you are interpreting the electrocardiogram, it will go for only mild mitral stenosis. I agree with you because it is more like an LV forces rather than because axis also is only because of teaching is that if the axis is beyond 60 degrees, below 60 degrees, most likely mitral valve orifice is more than 1.3 centimeter square. So it only indicates only moderate mitral stenosis at the most. So absence of right axis deviation is a strong point in favor of moderate or even mild metastasis. Okay, X-ray chest. Yes, anybody would like to interpret Aditya, or somebody would like to interpret the X-ray chest?
I will interpret.
Okay, right. Yes.
Sir, this is a chest X-ray PA view, which is showing there is a cardiomegaly. CTR ratio is around 0.6 to 0.7.
Very good.
And then there is LA enlargement. There is also apex is more of LV type. There is RA enlargement as well. And there is, I think, there is a double.
Now, what is the criteria that you are applying to comment about the LA enlargement and RA enlargement?
Sir, RA enlargement, as RA is occupying more than 3 intercostal spaces,
Yes,
and LA, we can see that there is the bifurcation angle that has become obtuse, as well as the concavity, normal concavity is lost of LA appendage, sir.
I am not able to make out that.
RA enlargement not there, sir. LA is more enlarged, sir.
Right. No, RA, see,
RA is there.
if you take the vertical height, it seems that it is occupying almost 1, 2,
3, 2.5.
More than 3, sir.
Borderline. Okay, borderline. I think I agree with the left atrial appendage is prominent. So there is evidence of left atrial enlargement. I cannot make out the carinal bifurcation very well. So I will not make any comment about the widening of the carinal angle. But
underexposed film, we can say, sir, underexposed film.
Eh?
Underexposed film, sir, because
slightly underexposed. So left atrial appendage is definitely prominent, and there is a cardiac enlargement. Okay, all those things go in favor of what? More in favor of mitral regurgitation.
So LV apex is also LV, more of LV type.
Yes,
so it is more is looking.
Yes, what are the
pulmonary? Then vasculature. There is syphilization is there. We can see vasculature. There is also dilatation of the right pulmonary artery, but the vasculature can be seen up to even the lateral 1/3. So it must be not a severe PH. It is.
I don't agree with you that there is a significant dilatation of the pulmonary artery. I would consider that right pulmonary artery is of normal size.
Okay.
But upper low vessels are syphilization.
Yes, prominent. And sir, left pleural effusion there, little pleural effusion.
Maybe there, I think there is haziness there. Maybe there's some degree of pleural effusion is there. What are the X-ray features? What are the X-ray features of?
Angle is clear.
There's some haziness.
Sir, left angle we can see, sir. I think it is breast.
No,
Breast shed only, sir.
Compared to the right angle, I would consider that left angle is hazy. So if somebody says that there may be some degree of pleural effusion, I will not object to it, because if you come, you can compare with other area, because it's if you compare the right angle with the left one is more hazy. So I think there is a possibility that there may be some degree of small amount of pleural effusion. And
sir, appendage is very prominent, no?
Not very prominent, is prominent. And pulmonary artery segment also is prominent.
Yes, sir.
And what are the X-ray features of pulmonary venous hypertension?
Sir, there is syphilization. Then there is curly B lines I can't comment on. Yes, and there is no evidence of alveolar edema. Then end-on vessels, some are.
Are you expecting large end-on vessels in this patient?
No.
No. So what can you expect? Do you know how will you interpret the peribronchial cuffing?
Yes, sir. This This peribronchial.
There is
No,
peribronchial. Even lower down, I am not able to show you that, but there is a peribronchial cupping seen in the on the right side, lower down. You can see a peribronchial cupping. Yeah, that's it. No, lower down, lower down. So there is a very one or two areas where the peribronchial cupping is there. So that indicates that the patient is having some degree of venous congestion.
Pulmonary venous hypertension is there.
Yeah,
So
yeah,
yes,
yeah,
definitely.
yes. That is a when there is a pulmonary venous hypertension, that is a point for us to start thinking whether the mitral stenosis is at least moderate. Okay, right. But cardiac enlargement goes more in favor of severe mitral.
MR.
Okay, right. Go ahead.
Sir, echo.
Sir, hello, sir. I'm Harshad. Hello.
Arshana, yeah.
Sir, what is the which criteria will apply, sir, for LA appendage enlargement?
You can see the. I'm not able to show you that. Saroj, can you show that? Because
What, sir? What?
he's asked what is the criteria for LA appendage enlargement.
Oh, sir. LA appendage, sir. This is aortic knuckle. Then, sir, pulmonary. And, sir, this is the LA appendix.
Yeah, I think LA appendage is very well clearly
It
seen.
has become prominent, sir.
Yes.
So when will say, sir, it is prominent means like any criteria for
LA appendage as the person who described the X-rays has shown. Usually that area is either flat.
It is normal. The angle, concave angle is lost of LA. Normal.
There is a bulge there, so that indicates left of the appendage is prominent.
Okay, sir.
Something happened to my. Okay, right. Yes.
Sir, echo.
Oh, okay.
Sir, 1 minute. Madam, how to go?
Hello, am I audible, ma'am?
Yeah. Now I.
Yes. Okay. Now you can open the video.
There are two videos, sir. But sir, of same. Sir, I took twice. It did not come well. That's why, sir. We will see 1 minute video, sir.
Okay, right. Something has happened to my. Aarti, are you there? Something happened to my screen. I am not able to see last one.
Yeah, no, sir. Video is perfectly visible. I am here.
Can you do something to see so that I can see the images very well? I am not able to see the images well.
Oh, sir, you are unable to see.
I can see the images, but they are very small.
We are able to see the video, sir. Can you swipe your screen, sir?
No, do one thing. I will now escape and then we'll come back again. I think that would be.
Yes.
Okay. You can rejoin the meeting.
Saroj, please wait for some time.
Yes, sir. Yes, sir. Sure, sir.
Let me first.
So should I start?
Yes, I think the doctor has rejoined. Let's wait for his audio.
So join.
Okay, fine. Yeah. Okay.
Sir, we'll restart, sir.
Okay. Okay, can one of the Gaurav, why can't you read?
Ma'am, from parasternal से लगा दो मैम. Parasternal, yes, yes, yes. It's a parasternal long axis view, sir. We can see both the AML and PML thickened, sir, and PML is fixed. Hello?
Yes, okay. Yeah, I'm hearing you. Yeah.
So, we can see the thickened both AML and PML, sir, and PML is fixed, sir. And
Okay.
here that MR jet in parasternal.
MR is not very significant. Eh?
Sir, actually, it has not come little better. I don't know some problem, but sir, MR jet is significant, sir. In the apical 4 chamber, we will be able to see, sir.
Okay. Because here
the color has not come good, sir.
Yeah.
And here is the short axis view where I think area was 1.4, ma'am. Area was 1.4, I think.
Yeah. And mean this much of MR, sir, mean gradient is only 9, sir. Mitral valve.
Main gradient is only 9. So obviously,
moderate on this one.
And sir, he has got a severe LV dysfunction, sir.
Oh.
We are not able to make out.
Sir, this MR, sir, that MR. So just here MR. So this
Here at least yes, moderate to see because there is a significant jet.
Yeah.
Yes.
It's a wall hugging jet, sir. No, wall hugging jet.
Yeah, wall hugging jet. Usually, in patients with rheumatic mitral regurgitation, the jet will be directed laterally and posteriorly.
So little AR was there, sir, which clinically I could not find, sir.
This AR I think it will be difficult to pick up.
Yeah. Yes, sir.
And sir, if MR is wall hugging, then that MR murmur also will not be able to. Radiation will not be if it is a wall hugging. So
no, wall hugging is the one which will be well radiated. The one which is going to the center of the left atrium may not be sometimes audible or may be very feeble. It is the wall hugging one which will be well audible and will be well radiated.
pH was how much was the pH?
31. It is 31, 41.
31. Oh, that means there's only a mild pH.
Mild. And TR was TR velocity. TR.
Grade 2.
TR
just see TR, this one.
Oh.
This is MV.
What is the pressure half time?
Sir, pressure half time, sir, it was coming. Just 1 minute, sir. So I think pressure half time I did not take.
Okay. Because you can always, of course, the most dependable one is the planimetric size of the left atrium, especially in presence of mitral regurgitation. So that is the most reliable one. So which is about 1.4 indicating
half time, not more, sir. We can say it is very slope is.
Pressure half time in presence of mitral regurgitation is less reliable.
So it was 1.4.
No, 1.4. Okay, so actually planimetry is the most reliable assessment of the mitral orifice.
Ma'am, thoda AS bhi hai kya? Aortic stenosis?
No, there was no AS. No. Little AR was
there. There is a very trivial or very minimal aortic regurgitation. Okay, right. Yes, LV function I am not able to assess properly.
Yes, sir.
Because in a patient with mitral regurgitation, if the patient has developed severe.
But LV appears to be normal size, sir.
So from here,
LV appears to be normal size. Sir, LV appears to be normal size.
In a patient with atrial fibrillation, you should be very careful in assessing the LV ejection fraction and LV function, because if you are recording at a very rapid rate of rapid heart rate, you may get all wrong data.
Sir, LV appears to be normal size, sir, whatever I am able to make out. LV is not.
No, that depends upon what is the depth that she has taken. What is the size of the LV, Saroj?
Sir, it was high, sir, 5.8. It was
Oh,
5.8, sir.
so that means obviously it is dilated.
Sir. Yes, sir. It was dilated, sir.
Mhm.
And patient
Okay.
admitted for mitral valve replacement.
Replacement. Okay, okay, right. Yes. I think so. So
The
what is your final diagnosis?
sir, chronic rheumatic heart disease
Hmm.
with severe mitral regurgitation.
Yes.
Sir, moderate, moderate mitral stenosis
Very good.
with sir, now sir, mild pH.
Okay. Smile pH. Probably with the diuretics and all, the
Yes.
patient were got well decompressed. And of course, the pH will be much more in patients with mitral stenosis than with mitral regurgitation.
Yes.
So here the patient is having moderate mitral stenosis. Okay. So
Sir,
what
with
further
moderate systolic dysfunction.
what further investigations and management?
Yes, sir.
And moderate PVH also, ma'am. Moderate PVH.
Yeah. Mild pH, moderate PVH also.
How can you diagnose moderate pH from echocardiogram?
No, sir. Sir, PVH from
X-ray.
X-ray.
Yes, yes. Okay, yes, okay.
Findings, sir,
Yes,
and
yes.
Now,
so, how will you investigate further, and what will be the management?
Yes, sir. Sir, I will investigate in the sense that because she has crossed 60 years now. Sir, so first I will go for the angiogram also.
Very good. You have to do a coronary angiogram to rule out any significant coronary obstruction.
Yes, sir.
Very good. Yes.
And she is 62, sir. So, sir, this is a borderline case for whether to go for a mechanical valve or for a bioprosthetic valve.
Okay.
And sir, first, sir, medical management, medical stabilization, angiogram. Then, sir, I will plan for sir, mitral valve replacement. Preferably, sir, now patient though in atrial fibrillation, but sir, I think if we go for a bioprosthetic valve, then sir, it will be more preferred.
Only problem is that the life of the bioprosthetic valve is only for about
15 years only, 13 to 15 years.
10 to 15 years. So the life expectancy of people, at least in Kerala, is very high. People live up to the age of 80, 85 and all. So I would recommend that she should go for a mechanoprosthetic.
Mechanical prosthetic valve. Okay, sir. Okay.
I think we have to consider now our recommendation similar to what is being recommended in the Western.
Yes, sir. Yes, sir. For mitral valve, it is 75 years. For aortic valve, it is sir 65.
65 or 70, I would consider both
70.
around 70.
70, sir. Yes, 70 and 70.
I would recommend definitely a bioprosthetic valve, and below that level, I would recommend a mechanoprosthetic valve.
Yes, sir. It will be mechanoprosthetic better because patient already in atrial fibrillation also. Yes.
So, what are the complications? No, sorry. What is the outcome of valve replacement surgery? What is the mortality?
Sir, mortality, sir, replacement, sir, around 5%. Sir.
3 to 5%.
3 to 5%.
3 to 5%. And aortic valve replacement mortality is?
Aortic valve, sir. A little less, na?
Little less, yes. It's about 1 to 3%. Other one, this is about 2 to 5%. Okay, in good sense, it's a safe procedure, and patients can undergo definitely a valve surgery without any problem. Okay, any other point? Good. I think a good case, good discussion. I think we could bring in from the history also. We could close down on the diagnosis. And
yes,
so,
yes, sir. You first only told, sir. I felt so good, sir. Sir, in the beginning, sir. So now we are learning that one, that how to go from history.
Because once you analyze properly, very often you can bring down the diagnosis to a very small number, and when you examine the patient, you can easily make the final diagnosis. Okay, I think it's very good. Next week, what should we have? Any doubts anybody having? Suppose you have got any doubt, you can clear it now. Okay, next week, anybody volunteers to bring a case? Or you want for me to present any spot test?
Next week, angiogram, sir. Angiogram can be.
Okay, we'll have spotters. We can have angiograms, or we can have echo, everything, a mixture of various hemodynamic data also. So we'll have spotters next class. Okay. Any, if there are no more questions, I think we'll stop at that level. Any doubts? So thank you, Saroj, for bringing the.
Thank you, sir. Thank you so much, sir.
I think it's a wonderful discussion. Everybody took part. And Gaurav, thank you for actively participating in the discussion.
Thank you.
Very good. I think everybody should participate. Gaurav is very always taking part in the discussion. Very good. I think that will give you a lot of confidence to face the examiner and examination. And I'm quite sure you can come out with flying.
I thought it was serious.
Okay. Okay. Good night. Thank you.
Thank you, everyone. So, sir, can I end the meeting with your permission?
Yeah. Okay. Thank you. Thank you.
Okay. So, I am ending this meeting. Thank you.
Thank you.